So we have Dr. Nidhi Gupta, who is going to talk
talk and for the opportunity, and because my topic was A to Z of chemical burns, I thought I'm going to only get you cases which I have managed from the first day of the presentation, so that after 10 years later, what is it that I have learned? At the end of it, I would only like to conclude with some take-home messages from these very examples. So when you see ocular surface burn, you see a variety of cases which vary in their etiology, in the day of their presentation, and also in the extent and depth of their injury. But when I see 10 years later, my practice, when I started treating chemical burns, and Shroff is at a place where you get a lot of acute burns, so you have an opportunity to learn and treat as well. I feel that it is the agent, it is the time interval between the injury of presentation and also the extent, not only the depth of the surface damage, the unitary and bilaterality of the injury matters, and finally what you can change is your management at every step whenever it presents. But the principle of management remains the same. At the acute stage, it should be a globe-saving surgery. At subacute stage, manage the inflammation, and at chronic stage only you start for bitumen rehabilitation. So you have a tailor-make approach you have to take from the various permutations and combinations of procedures that can be done on this eye when it presents with a sequelae of ocular surface burn. So starting from an example of a unilateral ocular surface burn, here is a 30-year-old patient who presents with 10 days of molten iron burn, which is actually a thermal burn, which is much deeper than a usual tuna burn injury. And at presentation, what you would notice, and I've tried to put that red mark because that is exactly what it is, perilimbal ischemia, which is missed, and it is different from a simple surface inflammation which you see otherwise. And what is going to help apart from the amniotic membrane is to do a tenonplasty, which is basically a procedure of getting vascularization to this perilimbal ischemia by pulling it all the way through from near the muscles, bringing it anteriorly and suturing it near the area of the ischemia. I would not go through for the whole of the slide of this of tenonplasty, but that is how this patient healed for the next 6 months. And if you will see, at the next 3 years of follow-up, this very patient that presented had a visual acuity of 612, and there was a lower cymbrifferon which was present. It doesn't require any management, and some amount of scarring with which he was fine. We could have done a dowel, but he was very fine with it. So with 612 vision, with a simple procedure of tenonplasty and amniotic membrane transplant, you are able to heal a patient of grade 4 injury. But sometimes, if you will actually trace the patients of perilimbal ischemia and they present late, then it can actually result in a melt like this. This is a last month's patient. We had a 6 weeks hot aluminium burn, and you would see the difference that the patient is presented with a large desmetocele and a perilimbal ischemia. What we did, and this was possible in emergency management, was to do a DALC in this patient. We were able to salvage this eye with a DALC, and the end of it we did an amniotic membrane grafting in this patient. I'll show you more patients wherein actually there was a perforation. But this patient in future is actually looking for a limbal stem cell transplantation and finally probably a repeat DALC for a good vision outcome. So we have printed our papers, printed work on scleral ischemia, and this was published in the Journal of Cornea, and this is different from Dr. Duval's work, which is the phenomenal work on chemical burn, on the basis of which we treat most of the patients, is that he did not define ischemia. What he said was limbal involvement. In our paper, we have defined what is perilimbal ischemia and what you should be doing. What we found in patients with perilimbal ischemia were two important things: that perilimbal ischemia, the more the clock hours of involvement increases and the depth increases, there are high chances of hypotony right in the acute stage, and if they present late, they'll present you with perforation. So managing perilimbal ischemia right in the beginning is very important with tenonplasty. It also impacts in long term the outcomes of SLED. This is another patient which presented with tuna burn injury, and I would just go through this patient that this was a more superficial burn, unlike the thermal burn, and this is how it resulted in total limbal stem cell deficiency. We all know the procedure of SLED. I'll not go through the slide of the SLED and the video, but it primarily gives very good results in patients with such kind of a presentation of total limbal stem cell deficiency. Not only SLED does improve or reverses the LSCD in these patients, it also improves the corneal clarity over time, and this has been the work by LVPI group. We also published our work along with the LVPI group and also with the other multicentric studies, and globally it has shown that 70 to 80% of the patients with LSCD, with unilateral ocular burn in chemical injury, can show very good outcomes with simple SLED without doing any other secondary procedure. The only two prognostic factors which are important are the grade of the cymbrifferon as well as the need for a penetrating keratoplasty at the time of the acute burn. So if you do not require any of these two, if they are not there, then you would have very good outcomes in these patients, and also pediatric age group does very well. Now this is a patient, and I just want to go on to the factor of symblepharon, how it plays a role. You will see this is a patient of thermal burn and 50% of the limbus is spared. But look at the way the symblepharon has progressed despite of us doing the tendinoplasty and AMG in the acute stage. And the next procedure we did was fornix formation with a simple sled. And this patient required a penetrating keratoplasty and a sled again. So patients of symblepharon, you're dealing with a much severe grade of a burn and you would require additional procedures. We did publish our work on the penetrating keratoplasty outcomes in patients of SLED in Journal of Cornea, and we found that the results for the next 1.5 years that we followed up. Now this patient is about 4 years. This picture is an old picture and he's doing well, very well. So we have patients about 6-7 years of follow-up also post-SLED who are doing very well with that graph. And that's an example of this child, 8-year-old tuna burn. This child at 8-year-old presented, and we did multiple procedures. We did fornix formation, the SLED procedure, then followed by PK and ECCIL. And now this child is 16 years old and he comes on his own and is a 624 vision maintaining for next 8 years of follow-up. So pediatric age group, if you treat it early on time and timely basis management, they do extremely well. Now patients of bilateral ocular burn are totally a different ballgame because they are the patients in which you do not have the other eye for the limbus, and that's why I'll just take 1 minute more. So in these patients, if you are not able to treat with a BOSP lens, then this is a patient where we have done an allosled, and immunosuppression is what you have to actually follow up along in these patients, but they do well. And this is one patient where there was a bilateral chemical burn with scleral ischemia and total corneal perforation. We, in emergency, did bilateral tendinoplasty with therapeutic PK. We were able to salvage one of the globes after 1 year of follow-up and underwent a Boston keratoprosthesis. So in patients of bilateral ocular burn, this is one of the modalities that you can use to rehabilitate, but we definitely over time have learned to do more allosled than Boston Capro in these eyes. And just the last patient to tell you that you would be requiring the need of an oculoplasty person if there is involvement of the lids. And they actually created the lid for this patient, and then we went ahead and did a Boston Capro, and this went well. So to conclude, I would just like to say, with all the experience of closely following up these patients for very long, scleral ischemia, perilimbal ischemia, diagnosing and treating with tendinoplasty in the acute stage extremely important. There's no doubt that amniotic membrane transplantation above grade and 4 has a long-term impact on LSCD. It's not a published word, but the randomized control trial only talks of outcomes after the acute stage. But if I follow up my patients of these on long-term, I've found it has an impact even on the outcomes of SLED. So doing an AMG is very important. Symblepharon management stepwise would give you very good outcomes. SLED has extremely good outcomes in patients of unilateral ocular burn, 70 to 80% success rate. Combine it with a PK and a DALC if you have a corneal scarring. And patients where you have bilateral LSCD, BOSP would be the first line of management, and allosled would be my second choice. And keratoprosthesis would be only my last resort. With that, I would like to thank you for your attention and time.
For a great